Hello and welcome, everyone. My name is Linda Martin, and I am one of the co-founders and the current board chair of Mission Cure. I am delighted to have you here with me today, and I'm here with my colleagues Megan Golden, Olivia Zeiden, Shruti Mira Shankar, and our summer interns. And we are delighted that you've joined us here for this webinar. I founded Mission Cure with our CEO and my colleague Megan Golden and her brother Eric. There are brand new treatments for autoimmune pancreatitis and pancreatitis caused by extremely high triglycerides. 5 companies are actively developing therapies for other types of pancreatitis, and 3 potential treatments are being tested in clinical trials in academic hospitals. This webinar is part of our patient education program, and we are delighted and thrilled that AbbVie, Amgen, and Ionis are supporting this effort, and we greatly appreciate this support. Now I will hand over the program to my colleague, Shruti Mira Shankar, who leads our patient education program, and she'll get us started. Shruti?
Thank you, Linda. And to our audience joining us live or on replay, thank you for your trust. Today's session is designed to deepen our understanding of autoimmune pancreatitis. Dr. Yasmin Hernandez-Barco will walk us through what disease progression can look like for pancreatitis patients and why identifying the cause matters before diving into the different types of AIP. We'll hear from Katharine Provencher about the connection between pancreatitis and IgG4-related disease and the shared experiences of patients and caregivers, along with resources available to the community. Autoimmune pancreatitis, or AIP, is often misunderstood and misdiagnosed. Many people go years without answers, and even after a diagnosis, there may still be uncertainty about whether that's correct. Diagnosis, treatment, and follow-up can vary greatly depending on the type of AIP and the experience and expertise of the doctors. We are doing this session because there's a real need for clear, up-to-date information, both for patients and for physicians. There's now a better understanding of AIP subtypes, its connection to IgG4-related disease, and what treatment and monitoring can look like over time. Our goal today is to give the patient community the knowledge and tools to have informed conversations with their doctors about AIP and to share best practices that physicians can apply in real-world care. Ultimately, we hope this leads to faster, accurate diagnosis, fewer unnecessary procedures, and more informed, effective treatment for those living with AIP. Now, it's my pleasure to introduce Dr. Yasmin Hernandez-Barco, a medical pancreatologist, scientist, and director of the Pancreatitis Treatment Center at Massachusetts General Hospital in Boston. She leads a multidisciplinary care clinic for pancreatitis patients and serves as an assistant professor at Harvard Medical School. This webinar is designed for patients, caregivers, and physicians alike, and we are fortunate to have her here to guide us through this complex topic. Dr. Hernandez-Barco, you now have our full attention. Over to you.
Thank you so much. Thank you really to all the organizers and the team at Mission Cure for the invitation to talk about this disease and really for everything that you do for the pancreatitis community. I think just as a provider that cares for patients, just the advancements that exist in the last few years is very exciting. So today I'll focus on autoimmune pancreatitis. Before I start, I think one of the things that's very important to know about autoimmune pancreatitis is that it's a very rare disease. It is super important to have the right diagnosis, just as Shruti said, and to not be misdiagnosed, because it is a very treatable form of pancreatitis. And so making sure you're with the right provider and that you're being diagnosed properly is of critical importance. There's 3 major types of autoimmune pancreatitis. The most common of these rare types is actually type 1 autoimmune pancreatitis. Other terms for this disease are IgG4-related disorder, IgG4 sclerosing cholangitis, and the bulk of my discussion today will actually be on type 1 autoimmune pancreatitis. So if you hear me go back and forth between AIP, IgG4-related disease, please know I'm talking about the same thing. At the end of the talk, I'll review what type 2 autoimmune pancreatitis is, and also briefly discuss type 3 autoimmune pancreatitis. So before we jump in, I always like to review the anatomy of all the things that I'm discussing, because I think having an understanding of what the pancreas looks like and how it interacts with the bile ducts is very important. If you look at the screen, sort of that yellow little tadpole in the middle, that's your pancreas. And there's a long tube running down the middle. That's called your main pancreatic duct. If you look at the little green sac on the left, that's your gallbladder. And if you trace down the little tube to where it connects with your pancreatic duct, that's your common bile duct. So when I talk about the pancreas, the pancreatic duct, or the common bile duct, this is the area that I'm talking about. Before I jump in, I think it's very important to recognize that we think of pancreatitis as a spectrum of disease. There's acute pancreatitis, which is a single episode of pancreatic inflammation, gallstones, medications, genetic causes, many different causes for this. And many patients will only have one episode, but there is at least a third of patients that will go on to develop recurrent acute pancreatitis, which means multiple episodes of inflammation. And if you have many episodes or you've had a very severe episode, you can progress to chronic pancreatitis, which means there's some scarring of the pancreas. And then these complications listed on the right-hand side are things that we want to look out for. One of the most important things I always tell my patients is make sure that we think very carefully about why you had pancreatitis, because as you can see here, there are different categories, and based on the different categories, or causes of pancreatitis, the treatment can be very different. We're going to focus in on today autoimmune pancreatitis and then discuss the treatment. So type 1 AIP or IgG4-related disease, please again, I will go back and forth between those terms. I'm referring to the same disease. It is a chronic fibroinflammatory disease that can impact almost every single organ in the body. When it impacts the pancreas, we call that IgG4-related pancreatitis or type 1 autoimmune pancreatitis. And when it impacts the bile duct, the same thing. It's the bile duct manifestation of this systemic disease called IgG4-related disease. Type 1 and type 2 autoimmune pancreatitis, and I'll discuss type 2 in a little bit, were classically considered the two main types of autoimmune pancreatitis, but as time has gone on and we understand a little bit more about what causes these pancreatitis episodes, these types of pancreatitis, they are very, very different diseases that happen for different issues in the immune system. So for patients with type 1 autoimmune pancreatitis, it generally impacts older individuals, which I don't think this is old, but 60 to 70 years old. There is a predominance to impact men more commonly than women. The most common presentation is actually that of a focal pancreatic mass that can actually mimic pancreatic cancer. We will often see in about 3/4 of patients an elevation in a blood test called IgG4. And another hallmark feature of this type 1 autoimmune pancreatitis is that you see inflammation in many different organs, not just the pancreas. And it's important to know whether or not you have type 1 versus a different type of autoimmune pancreatitis, because the risk of relapse after treatment is very high in type 1. And so choosing the right treatment is very important. So this criteria that is summarized on this slide, and I'll go into detail in the coming slides, is called the Heizort criteria. This was developed by Dr. Suresh Chari and the team at the Mayo Clinic. And it actually is used to diagnose both type 1 and type 2, but there are different features in both, so I'll focus on type 1 right now. It uses a combination of classic histology features, which means what you can look at under the microscope when somebody does a biopsy, classic features on imaging, either a CT scan or MRI, serology or blood work. There are different blood tests that we use to help us support this diagnosis. Looking to see if there are other organs involved, meaning is there inflammation in other organs? And then a last part of that diagnostic criteria is how a patient's inflammation responds to steroids, and I'll talk about that a little bit. I think one of the things that's most important, and I'll say it now and probably again, maybe 1 or 2 more times, is that not one single test can definitively make the diagnosis of IgG4-related disease. And so it really takes careful thought to put together a lot of these tests and make sure that you're receiving the right diagnosis. So the first diagnostic criteria is histology, which again just means biopsy of the pancreas. The findings that we see under the microscope, whether you biopsy the pancreas or the salivary glands, for example, or another part of the body, what we see under the microscope in IgG4-related disease is actually quite similar, regardless of which organ is involved. Some of these features include immune cells that we call lymphoplasmacytic infiltration, and sort of the pattern in which they're seen on a biopsy is really important. As you'll see in one of my upcoming slides, not every single person needs a biopsy, and a normal biopsy does not rule out autoimmune pancreatitis. So again, you can see it's a bit of a tricky diagnosis, but if you do see some of these classic findings, it can really help support the diagnosis. Imaging is a very important part of the diagnosis because about 40% of patients that have autoimmune pancreatitis will have what we call classic findings of autoimmune pancreatitis, which means a radiologist looks at it and those findings aren't really seen in other forms of pancreatitis. So some of those features you may have read in your reports are the sausage-shaped pancreas, which means a diffuse enlargement, or if you see a very long stricture of your pancreatic duct, if you remember that long tube running through the pancreas, or sometimes what's called a halo sign, which almost looks like there's a small thin line that wraps around your pancreas. Again, when these features are present, it can be very helpful, but oftentimes it can be a little bit confusing and make us think of other forms of pancreatitis as well. The other nice part about imaging is that you can look at other organs like your kidneys, your aorta, which is the large blood vessel that runs blood throughout your body, just to see if those organs are impacted by IgG4 disease. One of the things that I mentioned a little bit earlier is that not everybody needs a pancreas biopsy. And when we think of imaging for patients that have IgG4-related autoimmune pancreatitis, we put that imaging into two broad categories. The first is mass-forming pancreatitis, and the other bucket is diffuse involvement. When you have mass-forming autoimmune pancreatitis, you have to be super certain that you are not missing, God forbid, a pancreatic cancer, because anything that looks like a pancreatic mass is pancreatic cancer until proven otherwise. And these are the scenarios where you definitely want a biopsy. And the biopsy is not so much to confirm autoimmune pancreatitis, but to make sure that, again, God forbid, there's not a pancreatic cancer. When it's the diffuse involvement, which is the whole pancreas looks a little bit enlarged, in addition to thinking about autoimmune pancreatitis, just regular pancreatitis from all the other causes that I mentioned can look just like this. So it's very important to be very thoughtful of all the possible diagnoses before somebody says you definitely have autoimmune pancreatitis just on imaging alone. Very briefly, I want to touch upon this slide because as you remember from that picture where the bile duct and the pancreas come together, whenever there's inflammation of the pancreas, you can also have inflammation of that common bile duct, that little green tube. And the pattern of inflammation, there's about 4 to 5 different patterns that we see. Some of them can be related to the inflammation of the pancreas, but other patterns can actually mimic cholangiocarcinoma, which is a cancer of the bile duct, or inflammatory conditions such as PSC. And so again, this is a tricky diagnosis to make, and we use a lot of different clues to make the diagnosis. So it's just very important that if your bile duct is involved, that a provider confirms that this is IgG4-related disease and not a different disease process before letting you know that you have this diagnosis. So now we move on to blood work. It is called IgG4-related disease, but IgG4 is a test that's elevated in about 75% of patients that have IgG4-related disease. But you can still have IgG4-related disease with a normal IgG4 level, and you can have IgG4 elevations even if you don't have autoimmune pancreatitis. And so you probably are saying, how is this possible? But IgG4 is a molecule that comes to any site of inflammation. And so it's a little bit of a non-specific test, but in combination with imaging or biopsy, it can be very helpful. There's some exclusion clues that you can see here. And if you play back the webinar later, high fevers, a lack of response to steroids, very low white blood cell counts, things like this, that would rule out an autoimmune pancreatitis. But again, it's important that you're with a provider that's being thoughtful of all the different possibilities in your diagnosis. The fourth criteria is the presence of other organ involvement. As I mentioned, it can really impact any part of the body. And as you can see on this slide, that inflammation, those immune cells that you can see in the pancreas, it can also impact glands in your eyes, in your salivary glands, in your parotid glands, in the liver, the bile duct, around your major blood vessels, even in your heart, your prostate. And the presence of other organ involvement can support the diagnosis of IgG4-related disease. It's just important that your provider does a very good head and neck exam and looks for other parts of the body that might be involved. These are just some images of what that might look like. So on the left-hand side, you can see enlargement of the salivary glands. On the right-hand panel, enlargement of the lacrimal gland. Here on the left, you can see a lot of enlargement of the parotid glands. And then on the right, after treatment, that really has decreased in size. Same thing happens to the pancreas. There's a lot of inflammation, you see enlargement, and then with treatment, it all improves and the damage to the organs goes away. The last diagnostic criteria is a response to steroids. I do have to say that I've had a lot of referrals for patients that have been put on steroids over and over and over again, and they did not, in fact, have IgG4-related disease. So please be cautious that somebody doesn't just put you on steroids without a definitive plan for follow-up. A response to steroids is something that we use very specifically, most often when there's a pancreatic mass, so that mass-forming pancreatitis. The diagnosis might be in question, and you want to give steroids and see that mass of inflammation really decrease. If it decreases, then we feel much more confident that this is IgG4-related disease and we can move on to another treatment. If it does not respond, you have to think about another possibility. So one of the things I love so much about autoimmune pancreatitis is that it's treatable. And so I love when, I don't want any patient to have anything, but if you do have, we have a treatment and it can improve outcomes and quality of life. So the treatment goals for type 1 autoimmune pancreatitis are what we call induce and maintain remission, which means make all of that inflammation calm down and prevent the inflammation from coming back. And the reason for this is to prevent ongoing damage to the pancreas or any other organ. And I'll go into what that treatment can look like. There are 3 broad categories for treatment. One is steroids. This suppresses your entire immune system and it works very, very effectively, but there are a lot of toxicities related to this, like worsening diabetes, bone disease like osteopenia and osteoporosis. So even though it might be used as sort of your first line therapy, it's not something that you want to be on for a prolonged period of time or multiple times. Immunomodulators are another class of medications. They can be effective. They target more specific parts of the immune system. And then the third category is what we call biologic therapy. In this case, it's B cell depletion. B cells, you'll see in one of the slides, it's a very important immune cell that plays a big role in IgG4-related disease. So steroids, as I mentioned, you can see over 99% of patients respond to steroids. But once you stop the steroids, there's about 50% chance of having a relapse. And maybe in more recent studies, that risk of relapse is a little bit higher. And some of the risk factors for relapse as it relates to the pancreas specifically is if the bile duct is involved, if the IgG4 level is super high prior to treatment, or if you have multiple organs involved. I have the dosing that we generally use here in North America and in Europe. And it is important to note that in Asia, steroids are used to maintain remission, meaning long-term at much lower doses. But in the studies that were done in Asia, the complications that I mentioned, such as diabetes or bone disease, they weren't really seen. So there's probably something different in the population where perhaps this is a very good maintenance therapy in certain parts of the world, but may not be the best maintenance therapy in other parts of the world. Immunomodulators, I do want to touch upon it because, of course, they exist. They're used very commonly, especially depending on where you get care. And in certain parts of the world, immunomodulators are used because jumping to a biologic may not be covered, for example, in other parts of the world. The concern that I have with immunomodulators is that I find it very difficult to predict a patient's response. And then you have to use very high doses to get a patient into remission. And my concern with having to wait, what that means is if I put someone on this medication, there's still a lot of ongoing inflammation that can cause ongoing pancreatic damage. And I don't like that. I want to put somebody on something that I know is going to calm that inflammation down so that they don't have any more damage to their pancreas. So even though this is a good treatment option, if you're on it and you have good control, there's nothing wrong. I don't usually use it for my patients that are high risk for relapse. Before I jump into the biologics and B cell depletion, I just want to go over this little image, which is what I call the life cycle of a B cell. B cells are immune cells that when they see something foreign in the body, they make antibodies to try to bind to those foreign things and try to get rid of them. And so a B cell starts in your bone marrow, and then it moves into your periphery, your blood, your lymph nodes, and there is where it kind of makes antibodies. And so if you look down at the very bottom of this little box, you'll see something that says CD19 and CD20. These are molecules that sit on the top of B cells that tell you what type of B cell it is. You can see that a larger number of cells have CD19 on their surface and a smaller number of cells have CD20 on their surface. And I'll show you why this is important on the next slide. So as I mentioned, these B cells, which is where this little arrow is pointing, they are the ones that notice that there's something that shouldn't be there. And in this condition, perhaps they're sensing your normal tissue in a way that they shouldn't. But these B cells interact with T cells, which are actually the ones that cause a lot of damage to the pancreas and other organs. Rituximab is a medication that targets CD20. If you remember from the last slide, it targets a lot of B cells, but not as many as CD19. And for many years, rituximab was the most effective biologic therapy that we used. And so when we're able to get rid of those B cells can no longer talk to the T cells, and those T cells cannot cause damage. Inebilizumab, which this medication was it's the first FDA-approved medication for IgG4-related disease. And the data for this medication is actually quite remarkable in how effective it is at preventing ongoing inflammation and a relapse. And so it works again at the B cell, but you can see it's an anti-CD19 B cell, so it decreases more B cells. And so we think that this is a much more effective therapy than rituximab. And so it's wonderful that we do have an approved treatment now for patients that have IgG4-related disease. So to compare the two, they're both infusions. Inebilizumab, which is the anti-CD19 medication, it's a shorter infusion than rituximab. Again, it targets more CD19 cells. It targets more B cells. So we believe that it decreases inflammation probably better than rituximab, though they haven't been compared head to head. So both of these should be thought of if there's multi-organ disease, and definitely if there's ever a relapse. So any patient with a relapse, we should be considering biologic therapy, not steroids again. This is a summary of the treatment pros and cons. I think one of the pros of steroids is that it works, and it works very, very quickly. But the cons are, of course, some of the toxicities related to steroids and the fact that most patients will relapse after you take them off of prednisone. I've given my opinion on immunomodulators. They are there. If they work for you, there's no reason to change them necessarily, but it's a little bit difficult to predict who's going to do well on them. Biologic therapy, I think, is very important because it's really targeting the part of the immune system that the B cells, which are contributing to this disease, and you want to do it with multi-organ disease or high risk for relapse. So in summary, type 1 autoimmune pancreatitis, or is the pancreatic manifestation of the disease IgG4-related disease. The treatment goal is to decrease that inflammation so that there's no ongoing organ damage in the pancreas or in other organs. Steroids are reasonable, but the risk for relapse is very high. And if there is a relapse, should not be used as the treatment again. Definitely need to move on to biologic therapy. Rituximab and inebilizumab exist, but inebilizumab is the first FDA-approved medication. It's incredibly effective and it targets more B cells. And then we do monitor for the complications that I mentioned in one of those early slides, like diabetes, exocrine pancreatic insufficiency, low micronutrient deficiencies, because just like other forms of pancreatitis, anytime there's inflammation of the pancreas or damage, a patient can be at risk of these complications. So it's important to always be monitored at least once a year. And then I always put a comment here is that even though we have a great understanding of what causes IgG4-related disease, it is a rare disease. And so especially if there's a mass-forming pancreatitis, very important to rule out pancreatic cancer. Okay, so in the last few moments, I'll review type 2 autoimmune pancreatitis. The things that make type 1 and type 2 autoimmune pancreatitis similar is the fact that they're both immune-mediated diseases of the pancreas, and they both respond incredibly well to steroids. That being said, type 2 autoimmune pancreatitis is a different disease. It tends to impact patients a little bit younger. There's no real difference in terms of distribution between male and female patients. It typically presents with more of an acute pancreatitis rather than a slow inflammation with very mild symptoms, and pain is much more common in this condition. IgG4 levels are not routinely elevated, but there is a pretty significant association with inflammatory bowel disease. It was estimated that about 30% of patients have inflammatory bowel disease, but on more recent studies that have come out of Europe, the long-term follow-up, it actually may be as high as 80% of patients with type 2 autoimmune pancreatitis may also have inflammatory bowel disease. We probably need more studies to confirm that observation, but there is quite an association there. One of the things that's important to know about this condition is that it is very, very responsive to steroids. Greater than 90% of patients will be treated with one course of steroids and then never have issues with their pancreas again. And so if there is a flare, it's very important to think, okay, did I make the right diagnosis, or could there be a different cause? So type 3 autoimmune pancreatitis, this is a term, again, that Dr. Chari developed. And what it signifies is something called ICI, or immune checkpoint inhibitor induced pancreatic injury. And again, the reason why it's called type 3 autoimmune pancreatitis is because it's an immune-mediated injury of the pancreas. And immune checkpoint inhibitors are actually cancer medications that are wonderful and have revolutionized cancer-related care, but it can cause autoimmune-like issues in other parts of the body, like the colon, the liver, the pancreas. When it impacts the pancreas, again, it's very rare, as you can see, maybe 0.5% to 4% where these medications can actually injure the pancreas. And most of the time, it actually just causes elevations in pancreatic enzymes, what's called lipase or amylase. To cause true, I put true, quote, pancreatitis is even more rare, less than 2%. The reason why it's important to recognize this as a possibility is because the treatment is actually quite different. And what you can see here is that patients on this medication can actually develop a lot of atrophy of their pancreas and may present with exocrine pancreatic insufficiency, even if they didn't have a true acute pancreatitis. And so it's important to be vigilant, but usually the treatment of the cancer is an even bigger priority. And I'll summarize this in the next slide. The major difference between type 3 autoimmune pancreatitis, or the immune checkpoint inhibitor pancreatitis, and the other forms of pancreatitis is that because it's being caused by a life-saving medication for cancer, we will oftentimes try to avoid treatment with steroids. We actually want to give patients supportive therapy with IV fluids, make sure they're able to eat, and really only do we stop the medication or treat with steroids if a patient has severe symptomatic acute pancreatitis. Otherwise, it can impact their cancer treatment outcomes. So just to summarize, you can see here there's a long list of symptoms, and there's a lot of overlap between these conditions. There's also a lot of overlap with other forms of pancreatitis. And so I put this slide here mostly to say that it is possible that you have autoimmune pancreatitis. I think it takes very careful history, careful testing to make the definitive diagnosis of autoimmune pancreatitis and not have another form of pancreatitis missed. And then in just my last minute, I just want to summarize that any form of pancreatitis, whether autoimmune or other, a patient can be at risk for developing complications such as diabetes, exocrine pancreatic insufficiency, or micronutrient deficiency. And so it's very important that a doctor or provider screens you and asks you specific symptoms, or you look out for yourself. Greasy stools, oily stools, sticky stools, difficult to wipe, anything like that could mean that maybe your pancreas is not making enough enzymes. There is stool-based testing that can help. Checking your vitamin levels to see if you're having any issues with absorption is also very important. And then especially if you have chronic pancreatitis, you want to make sure that somebody's checking on your bones every couple years. And of course, if you have any of these symptoms or there's a suspicion for exocrine pancreatic insufficiency, you want to make sure that you're being treated with pancreatic enzyme replacement and that somebody's discussing nutritional options to kind of optimize your quality of life also. Okay, so this is my personal feeling and why I'm very grateful to work where I work. But I think taking care of somebody that has pancreatitis, whether it's autoimmune pancreatitis or other, you really need a team because a patient may come to you with one symptom, but it impacts their whole life. And so making sure that you're addressing pain, nutrition, other organ complications, I think is very, very important. And we try to do that here at MGH. We also have a dietitian that we work with because that's so important and something that's important for us, but really important for patients, as you all know. And then we already went through what sort of complications to look out for. And these are some resources, but thank you again for your time. I'm happy to answer questions at the end.
Thank you so much, Dr. Hernandez-Barco, for helping us better understand AIP and for providing a bird's eye view of the natural history and treatment approaches for pancreatitis patients. We deeply value your vision and your commitment, along with action, to ease the burden of this disease through your work at the Multidisciplinary Care Clinic. We want to see more such clinics across the country and around the world so that patients receive the care they need and deserve. Now, I welcome Katharine Provencher, Director of Advocacy and Community Engagement at IgG4, where she leads efforts to support and empower the IgG4-related disease community. She's also a caregiver and social worker with over 20 years of experience in patient advocacy. Her insights and experience bring a vital perspective to our discussion today, especially for patients and families navigating immune diseases affecting multiple organs. Katharine, over to you.
Hello, and thank you so much for that beautiful introduction. I greatly appreciate it. And thank you so much for giving me the opportunity to come and be a speaker on such an important webinar. It truly was an honor when I received the request to participate in such, like I said, an important webinar for our community. Hello, again, my name is Katharine Provencher. I'm here both as a caregiver and as the Director of Advocacy and Community Engagement for the IgG4 Foundation. Today I'll be sharing both my personal experience, which to me is one of the most important experiences when you're dealing with a rare disease, and the voices of those that I represent in the IgG4-RD community. I will also be sharing information regarding the IgG4 Foundation for those that are just being introduced to us today. And I want to make note that my husband, who you can see on screen right there, lives with IgG4-RD. His pancreas is not affected. His lungs are. But through my work with the foundation, I have really come in contact with so many individuals and their families that are navigating pancreatic involvement. And although, different organs, very similar journeys. So as we heard earlier from the wonderful presentation before me, it's a very hard act to follow. IgG4-RD is a chronic immune-mediated condition that can affect nearly any organ system. The pancreas and the bile ducts are among the most common within IgG4-RD, and unfortunately, we hear so often that many patients are initially misdiagnosed with pancreatic cancer. I've spoken with people who have undergone major surgeries, including the Whipple procedure, before IgG4-RD was even considered. Others have spent years without answers, enduring referrals, inconclusive scans, and even more uncertainty that weighed heavily on them and their families. And after diagnosis, the journey, as we all know, it continues. It doesn't just stop once you receive that label. And those living with AIP, IgG4-RD, face a lifelong path of potential flares, treatment decisions, ongoing monitoring, and constant adaptation. And it's not just a medical condition. I always want to make point of that, and that may be the social worker within me, but it's lived experience that impacts every aspect of the patient and their family's life. So I'm going to talk a little bit about the caregiver experience, which obviously I have some personal experience there. And what I have learned personally and also being in this community for about a year and a half now is for many caregivers, the hardest part, again, is that uncertainty. And that diagnosis often takes months or years. So just constant worries within your brain circling around. And for caregivers, we truly carry our loved ones through medical questioning, growing anxiety, and endless testing. My husband began his journey after a freak accident. He had a mountain biking accident about 5 years ago, and he was told in the ER that he had stage 4 lung cancer. So I did what so many of us do, whether you're a partner, a friend, a mother, etc. I became the note taker. I became the scheduler. And what I feel most important, a role that I played was our family's emotional anchor. And, I also researched symptoms. I tried the best that I could at translating lab results, which I don't often recommend without a physician there next to you. But I really pushed to make sure that my husband Andy's doctors were listening. And that's very, very important. And I've heard among other caregivers, again, that even after diagnosis, that advocacy, it doesn't stop. And sometimes we even need to increase it a little bit more. We're hearing among the community that most people, even healthcare providers, still don't know about IgG4-RD or even autoimmune pancreatitis. We find ourselves explaining the disease at every appointment, if it's a new provider or we unfortunately have to visit an ER, we have to explain what it is. And that's hard. Fighting for awareness and ensuring treatments and being taken seriously are so, so important. And it's very exhausting to continue to do this day in and day out. But what I've also learned, and I see it among our community, is that we are very resilient. And it's a strength that is born from love, from frustration, unfortunately, and determination to give our loved ones the best possible life they can have while living with this disease. That is why I was, again, so, so excited to be a part of this webinar because it's collaboration like this that is so important. That's how we get the word out. That's how we raise more awareness and shrink those diagnostic journeys just a little bit. So just a little bit about IgG Forward Foundation. If you don't already know, we are the first nonprofit that's solely focused on IgG4 related disease. And thankfully, to our executive chairman, Dr. John Stone, he founded the foundation in November of 2023. And it's really a home, a trusted area for international individuals, for individuals within the United States, for patients, for caregivers, for physicians, everyone to please come and join that needs to learn more about IgG4 related disease. And our mission is simple, but it's powerful to support, educate, advocate, and advance research for everyone that's impacted by IgG4 related disease. We offer so many resources. I'm really excited about the amount of resources that we already have out there for the community because when I first found out that my husband had IgG4 related disease, there was nothing out there. We found misinformation. We eventually landed on one video that was an older video of Dr. Stone that we found trust in and a good resource. But now we have webinars, we have fireside chats. Please take a look because we've hosted a few webinars specific to pancreatic involvement and also a wonderful webinar regarding nutrition and wellness for patients specific with AIP. Of course, because, that clinical social worker in me, I can't let this go unnoticed. We offer mental health resources, caregiver support. It's very, very important. Like I said before, your lives have been thrown in a blender, shaken up a little bit, and that has an impact on our whole self. So it's really important that we recognize that. Our annual patient jamboree, which we have started to call the Jam, we hosted our first one last year in November, which was such a beautiful event where we got the community together, most people never meeting anybody before with the disease. So to witness that was so powerful. We're hosting another in Atlanta. It's going to be called the Peach Jam in September 12th to 13th. So just a wonderful way to educate the community, bring us all together. Another resource that I'm really proud of, if you're looking for a doctor familiar with IgG4-related disease, please go on Education and Resources, go to our physician network, and you can search your zip code, your area, and it'll bring up a physician that's familiar with the disease, that treats the disease for you. So if you're looking for somebody knowledgeable, that's great. I'm also extremely excited for another resource that we're offering to the community. It's through a company called MyMejo. It's the IgG4Me app. And I know, again, personally, we had Post-its, we have notes in every single room of our house, on our phones, what have you, regarding my husband's appointments, illnesses, etc. But with this app, you can keep that all in one place, including scans, anything you feel comfortable uploading into the app, you basically can. So I'm really excited. Stay tuned for that. Also, all of these resources are available on our website, igg4word.org. And as I finish up here, I thought it was really important to not just hear from me, but also I wanted to quote some of the individuals that have pancreatic involvement and some powerful things that they have said to me, such as, I was told it was cancer. It wasn't. I had my pancreas removed for nothing. That quote really has stuck with me ever since that individual told me that, because again, why we need the education and awareness, because that shouldn't happen. The doctors need more information. Yes, I couldn't agree more. And I wish they had tested for IgG4 sooner. So as the director of advocacy, I believe that people want to be believed. They want to feel understood, and they want access to resources, to the right care, and they want help navigating their journey with confidence. And connection really helps with that, and these type of webinars help with that. So I also invite you to connect with us, IgG Forward, and whether you're a patient, caregiver, clinician, advocate, we welcome you. Please visit our website, our socials. There's power in knowing that you're not alone. And I've learned that over this year and a half, and that you don't have to navigate the journey in the dark. So again, thank you, Mission Cure, for inviting me to be here to show people that there's a larger community out there and to bring more education and awareness. Thank you.
Thank you so much for your work with Dr. Johnstone and the Foundation, Kat. I know Katharine's insights resonate deeply with many of us. You're using your personal insights and experience in shaping how patients and families are supported in the world outside is heartening and inspiring. Thank you so much. All right, everyone, it's time for our Q&A session. And Linda, I'm going to hand it over to you.
Thank you, Shruti. And thank you to both of our speakers. That was truly enlightening. And I know everyone on this webinar has learned a lot. And if the Q&A is any indication, it has created many, many questions. So we will do our best to get through as many of them as we can. If we can't get through all of them, we will do our best to follow up with others individually and on our website. And although our webinar is scheduled to end at 1 o'clock, our guest speakers have agreed to stay a little bit longer if necessary. And we understand that you may not be able to, but if you can, we will try to get through as many of the Q&A as we can. So with that, I'll get started. And these are not in any particular order. First of all, are patients with IgG4 disease at risk for blood cancer, such as myeloma or other solid tumors? And I think, Dr. Yasmin, that goes to you.
That is an area that is currently under study. So there may be a slight risk of cancer such as lymphoma. Solid cancers in some of the older studies have shown a slight increased risk of pancreatic cancer in patients that have IgG4 disease. What I think is a little bit difficult to know in those scenarios is because, as I showed, that sometimes autoimmune pancreatitis can present as a mass. Pancreatic cancer can cause a lot of inflammation around it. So it's difficult to know if it was misdiagnosed as IgG4 that later was determined to be pancreatic cancer, or if there truly is an increased risk. I can say that our center is currently working to do this. There's a whole team in Germany that's also trying to better define what cancers are associated with autoimmune pancreatitis. So we'll have a much more clear answer to that, hopefully in a year or so. But the short answer, which I give you a long answer, is that there's probably a slight increased risk, but we need more studies with more patients to really know that association.
Thank you. And on a similar but different track, we have a few questions that really are asking about the link between other autoimmune conditions, specifically lupus and others, and chronic pancreatitis.
Lupus, it's a systemic immune-related condition. It is associated with acute pancreatitis, recurrent acute pancreatitis, but it rarely is associated with chronic pancreatitis. Even though lupus is an autoimmune condition and it can lead to acute pancreatitis, what causes pancreatitis from lupus is actually different than IgG4-related disease, changes in the immune system. Usually when lupus causes pancreatitis directly, it's because of issues with the circulation in the pancreas. But with patients that have lupus, they're exposed to a lot of different medications. They have changes in their metabolism, including triglycerides, and all of those things can contribute to pancreatic inflammation. So there are rare case reports of chronic pancreatitis and lupus, but usually what you see is acute pancreatitis. Either the lupus itself has caused it or medication or metabolic changes related to it.
Makes sense. Thank you. We have several questions that are very important, but a little hard to summarize. And they really relate to having a number of symptoms and not a clear diagnosis. And so I will try to give a few examples along the way, but let's start with, could I be having type 2 autoimmune pancreatitis despite negative IgG4 and ANA, given that my stool elastase is very low? CT showed bulky pancreas, but EUS showed no enlargement. EUS suggested mild chronic pancreatitis with unclear cause, but I have a shared family pattern and I experience non-diabetic reactive hypoglycemia. How should we further investigate the possibility of type 2 AIP? And I would say that there's several questions that are along these lines of, we've gone down this path, how do we further investigate?
Okay, I'll start by saying you need a provider that really is going to sit with you, think about things, and go through everything systematically, or review all the testing that you've had systematically to make sure that you've had a good evaluation. And I see a lot of patients that have seen many different people and heard many different things. And so I really just want to say that I know how frustrating that is and the despair that you can live in when you don't feel well and you know something could be wrong. So again, the short answer is yes, you might have type 2 autoimmune pancreatitis. That's always possible, but it's a very rare diagnosis. So one of the things that I'll go through each sort of thing here, and maybe it applies to other people's questions. A low stool elastase, the first thing is you want to make sure it was a true low test. So the stool elastase test is actually a test that measures the concentration of elastase. So it actually has to be a very well-formed sample that's not soft or mushy or watery, because it can give you a false low result. So assuming that the test is accurate and you have some changes in your pancreas on imaging, it does make me worry that there is something causing pancreatic injury or some kind of low-level pancreatic inflammation. Again, type 2 autoimmune pancreatitis is very rare, so I would make sure that there's no family history of pancreatitis, because that might represent a genetic predisposition to pancreatitis, and that can sometimes cause these very mild findings on imaging. You also want to make sure that there are no medications that you've been receiving that can predispose to the low blood sugar or to ongoing pancreatic inflammation. I have to assume, but you never assume, that calcium levels have been checked, triglyceride levels have been checked, no tobacco exposure, no alcohol exposure, because even tobacco and alcohol in the setting of a genetic predisposition can augment the risk of pancreatitis. And so if all of those things have sort of been thought about and ruled out, and there really is an abnormality of your pancreas, talking to an interventional endoscopist that does biopsy of the pancreas to see whether or not they find a safe place in your pancreas to biopsy that would probably be the way to determine whether or not this is type 2 autoimmune pancreatitis. The thing is, I don't want you, running and saying, take a biopsy, because the biopsy itself can actually cause acute pancreatitis. So that person doing the procedure really has to see a clear area to do that biopsy safely. You can also discuss with your provider if a trial of steroids would be reasonable. Again, for each individual patient, a trial of, if you do steroids and everything improves, then that can help support the diagnosis. But steroids are not benign medications, and so you really have to be super careful. That was a very long way of saying that you just talk about it and make sure that the explanations that you receive from your provider are things that you feel comfortable about, you've had all your questions answered, and if not, you set up a second visit and say, I'm sorry, I have more questions. Can I see you again in a few weeks? Just to make sure that you feel that everything, all your concerns have been addressed.
Okay, here a couple maybe just shorter answers.
So,
No, not your answers don't need to be short. They're shorter questions, so maybe. Is there a relationship between pancreatitis and IgG4?
to our knowledge, IgG4 is not associated, does not give us any information on whether or not somebody has autoimmune pancreatitis. But
Okay.
because you check the full panel, you can see elevations or decreases. They're all immune related changes, but we don't use it for the diagnosis.
Okay. And how are patients with beef, pork, mammal allergies, protein or alpha-gal carb treated?
This is very difficult because currently all of our pancreatic enzyme replacement therapies that are FDA approved are all porcine derived. There are some over-the-counter plant-based or yeast-based enzymes that are not as effective, but one of the things that you primarily have to tackle that with diet, a diet that's more based, that has more medium chain fatty acids that are a little bit easier to digest, and then you have to spread out that fat consumption more throughout the day rather than all at one meal. It can help the bit of pancreatic function enzymes that you do have. It can help you digest those fats a little bit more easily than just a regular fat diet, but it's a big challenge. But there are studies that are looking at more synthetic versions, so thank God that there will be options for people in this situation, hopefully soon.
Yes, and I can add to that and confirm that we are in partnership and conversations with companies and research organizations that are working on these alternatives to dealing with PERT and other parts of that condition. So stay tuned. There's good news coming. Is it possible to have autoimmune pancreatitis and a genetic cause like PRSS1? And how do you explain the broader immune system pancreas connection, since many patients with different types of pancreatitis get flares during viruses?
So yes, you can certainly have two etiologies for pancreatitis. It would be very, very rare to have a genetic cause of pancreatitis, especially PRSS1 and autoimmune pancreatitis, but it's certainly possible. Anytime that our immune system needs to become activated from viral infections, bacterial infections, the whole immune system does become activated, and it can cause either flares in pancreatic pain or true acute pancreatitis, especially depending on the cause, either the virus that you have or the underlying cause of your pancreatitis. And so the reason for that is a lot of the same molecules that are increased in acute pancreatitis are also increased when fighting off certain infections. And so it's one immune system that works in a very complex way, but what you're feeling and experiencing, we do see.
Okay, great. And what diagnosis and infections should be ruled out when neuroantigens are elevated?
Neuroantigens usually refer more to antigens that can impact more the brain. And so I'm not sure if I fully understand the question, and perhaps maybe I can follow up with the person that asked offline afterwards. I definitely want to make sure I answer, but I'm not sure if I understand it.
Perfect. Yes, and I think several of our additional questions are going to fall into somewhat similar categories that are sort of personal experiences, and I will give you a couple that may allow you to answer things that might help others, and then For the rest, I think probably a individual follow-up makes more sense. Okay, we need help in a consultation. My brother has been going from doctor to doctor for 2 years and we still can't get a diagnosis. His IgG4 levels keep rising and are already 4 times above normal. Preliminary diagnosis is AIP, but MRI and PET scans are normal, while ultrasound indicated AIP. All neuroantigens are elevated. There are many symptoms, and then basically follow up in terms of consultation or next steps.
This is difficult because the IgG4 is a bit of a non-specific marker, and we do see elevations in IgG4 levels in, of course, type 1 autoimmune pancreatitis, but you can see it in a lot of other conditions. There are additional blood tests that usually are checked to help support the diagnosis of IgG4. These include a total IgG level, a total IgE level, liver function test. We also will use complement levels, C3 or C4. We do rely heavily on imaging, and a PET-CT is usually a pretty good test because it can evaluate the entire body and look for any areas of inflammation. If a PET-CT is negative, an MRI of the pancreas is negative, meaning it appears normal, and there's been imaging of the chest and also of the head and neck, and there's no evidence of inflammation, then either this means it's IgG4-related disease in its very, 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 very early stages, which is less likely because usually we see something, especially if you have an IgG4 level, it directly correlates with the level of inflammation in the body, or it's another disease. And so, I feel badly because, it sounds like you've been going to a lot of doctors without an answer. And so perhaps I might touch base with a rheumatologist that can give a fresh set of like a new perspective and just make sure that a different immune-related condition isn't being missed, especially if the imaging's all been normal.
I will ask just a couple of more questions along these same lines in the hopes that sharing this information will help others on the call as well. I know from being the caregiver of a daughter with chronic pancreatitis, the diagnostic journey and then the treatment journey is very frustrating, and little tidbits of information that may apply to your situation can be so helpful. So I will carry on here with a few more minutes and then we'll wrap up. Can a patient with a history of pulmonary sarcoidosis have an elevated IgG4? If a pancreatic cyst remits on its own, is this more indicative for acute pancreatitis or could it be an autoimmune pancreatitis? Can you have both pulmonary sarcoidosis and autoimmune pancreatitis?
Yeah, you can have an elevated IgG4 level with pulmonary sarcoidosis. As I mentioned, IgG4, it's a molecule that's released in the setting of any type of inflammation. And we detect it in the blood, but if your IgG4 molecule is going to the lung or to other parts of the body to try to help calm the inflammation from sarcoidosis, that could be what gives you an elevation in your IgG4 level, even if your pancreas is okay. Pancreatic cyst that you have and then completely go away, and I don't trust just one imaging study. I'm a little bit more cautious. I like to know that it's fully gone, and then I like to check one more time in 1 year to really make sure, is more likely to be related to pancreatic cyst rather than mucinous cysts like IPMNs. But I do like those 2 data points where I have 2 normal exams before I feel comfortable saying that.
Sort of a general question. How can we proactively look after our pancreas before it becomes CP or even after? Our yearly screenings, DEXA scans every 2 years, recommended or needed for all recurrent, acute, and chronic pancreatitis patients.
So I think what's important to know is that the pancreas has 2 major functions. It makes hormones to regulate your blood sugar, and it secretes pancreatic enzymes to help you digest protein, fats, and absorb very important nutrients. Anytime you've had injury to the pancreas, either with one episode, a very severe episode, or multiple episodes, those 2 functions can become compromised. And so you, at a minimum, especially if you have no symptoms, you want to make sure that at least once a year you're being screened for diabetes. And 2, you're being vigilant about those symptoms of exocrine insufficiency, like loose stool, greasy stools, weight loss. But also your provider should be asking you this and maybe even incorporating stool-based testing at least once a year. If you have chronic pancreatitis because of the inflammation that exists in the pancreas at a low level, you should also have a baseline bone density exam. And if there's any abnormality, that should be something that's checked every 2 years. And the last thing is, if you have exocrine pancreatic insufficiency, all of our guidelines tell us that we should check all of your vitamin, not every vitamin, but a set of vitamins every year to make sure that you've not developed any deficiencies in important nutrients like zinc, selenium, the fat-soluble vitamins. And then if they are low, you want to replete them and make sure you're on a good dose of pancreatic enzymes.
Very helpful. Okay, for one final question, we have a person who is attending from the Ukraine, and they've been given a preliminary diagnosis of autoimmune pancreatitis, but the doctor suspected it is unsure since the MRI with contrast appears normal. He referred this person for neuroantigen testing, all came back elevated. Now he's sending this person for differential diagnosis of autoimmune encephalitis. Do you have any comments about the situation?
I think the individual also asked one of the questions a little bit earlier about the neuroantigens, and I was sort of reading through the questions. This is a very, very complex situation, and I want to be helpful. I think seeing a little bit more of the information will be important because I don't want to give false guidance that then brings you through so much more testing. That being said, IgG4 can impact the parameninges, things in the brain. So it is possible that this could be related to IgG4-related disease. The autoimmune encephalitis is a different disease entity. So I just want to be careful that I'm not confusing things more than helping, but I'm very happy to follow up sort of after this.
Thank you. I think that's all the questions that I have, but I believe that there may be another question or two from the panelists.
Thank you. This is Megan, and I just noticed that there were 3 questions relating to whether nebulizumab is a better option than rituximab. 2 people saying they were about to start rituximab after having multiple attacks, and another asking about whether you can change from rituximab to nebulizumab.
No problem. So I saw that question also about many rounds of steroids and now rituximab. Rituximab and inebilizumab decrease your B cells. They work. If you stay on them, they will help prevent ongoing inflammation from IgG4-related disease. So you will not have that experience of having to go on steroid and then steroid again, and then, and the disease is not controlled. So these are very effective therapies. I feel more comfortable with inebilizumab because we have very, very robust clinical trial data now that shows us how effective the medication is for patients that have multiple organs involved. But we also have almost 10 years of data on using rituximab. So I would say if you are already set up for your rituximab infusion, I think because it sounded like one patient is about to get it next week, I would probably move forward with that because you do want to stop the inflammation that you've had ongoing for a while. But if you're still in the process of discussing the diagnosis or potentially what treatment options, inebilizumab is what's FDA approved. It does target more B cells. And so it's probably worth discussing that as an option with your provider.
Great.
Thank you.
Okay, well, that brings us to the end of Q&A, and I will hand this back to my colleague, Olivia.
Thank you, Linda. And thank you to everyone who joined us today. On behalf of the Mission Cure team, we want to extend our sincere gratitude to Dr. Hernandez-Barco and Katharine Provencher for their time, effort, and support in making this webinar possible. It was such a pleasure to hear from both of you. We post resources for our patient community as part of our patient education program, so please subscribe to our newsletter on our website and follow us on social media to learn more and watch more webinars like this one. You can explore past webinar recordings anytime on our website or YouTube channel. If you have questions or comments, feel free to reach out. We'd love to hear from you. Thanks again, and we hope you enjoy the rest of your day.